Thank you very much indeed for the invite. So my talk will be heavily loaded in the first part and just the how of operating the frontal sinus, and then we'll have a short break and then a short final segment. So the frontal sinus, it develops from birth, and really it's an invagination into that frontal bone. Not everybody will have a frontal sinus. Maybe up to 10% have a very diminished unilateral frontal sinus. As with all our sinuses, there's a mucociliary clearance pathway, and if that's interrupted and it's pre-programmed at the natural ostium, then sinus disease will develop. I'm not going to do much on the anatomy, but knowing the anatomy of that frontal recess is obviously absolutely essential in operating in this area. As a simple concept I have in my mind, I start with the agonase cell, and then I'm asking myself from the scans, are there any frontal ethmoidal cells which are encroaching above that and narrowing the frontal sinus from its anterior aspect? Then I'm looking to the medial aspect. Is there any intersinus septal cells which are encroaching on that frontal recess? And then finally, are there any frontal bulla cells which are creeping up that posterior skull base, again narrowing that frontal sinus down? And getting an idea from free planes on that CT where those sinuses cells are will dictate where the frontal recess will be. It can be a very simple pathway, it can be a very complicated pathway. And ultimately, the distance from the beak to posterior skull base is what will dictate the final dimensions of anything in the frontal sinus there. So, going to look at some simple surgical access. And the mini trephine is an absolutely fantastic way of getting into that frontal sinus. It can be done under a general anaesthetic or a local anaesthetic. And it's specifically good if you're thinking about having to operate on a hot sinus, i.e. An acute infection in that frontal sinus. It's quick, it avoids damage to the frontal recess, which is a really important bit. And you're able to irrigate and drain the frontal sinus. It's also useful if you want to identify the frontal outflow tract. So this is an old video, but it shows it quite well. The mini trephine is we're making an incision 1 centimetre from the midline in the eyebrow. We're using a little guide and a drill system, which only allows you to penetrate 12 millimetres. You need plenty of irrigation when you're doing this, but it allows direct access into the front wall of the frontal sinus. We can then insert a guide directly into the frontal sinus now, and that's used to insert the cannula. And it's basically a half-quarter turn, and it locks it in place. We've got direct access to the frontal sinus now, and we can flush it out, and we now have an endoscopic view of mucus coming out at the frontal sinus. Another simple approach to the frontal sinus would be balloon sinuplasty. Again, that can be done under a general anaesthetic or a local anaesthetic. And it works on the principle of using a little guide wire to negotiate blindly the complex anatomy in the frontal recess. And then it uses balloons to microfracture cells. The essence is that you're preserving the mucosa in that frontal recess. So this is a typical picture you would find where we've inserted a guide wire into the patient and we've got that target sign on the frontal sinus. In the nasal cavity, we have the uncinate, ethmoid bulla, and middle turbinate. We're using the anterior face of the ethmoid bulla as our guide into the frontal sinus. We are gently probing to find the recess. Once the guide wire is in place, we can insert the balloon. Usually the balloon is blown up in 2 to 3 segments to enlarge this sinus tract. We can irrigate through if necessary, and then have a look and find an enlarged opening into that frontal sinus. Obviously, the main operative procedure for frontal sinus for most of us will be endoscopic sinus surgery. And my principle is really, we've got to unobstruct and importantly preserve the outflow mucosa on that frontal recess. Hopefully everybody knows that the draft classifications. Type 1, simple drainage by aneuphoidectomy. Type 2, where we're essentially removing the floor of the frontal sinus from the lamina up to the middle turbinate. Type B, we're removing the floor of the frontal sinus from the lamina over towards the septum. And the type 3 is really two type Bs with removal of the septum in between. In operating the frontal sinus, as opposed to all my other sinuses, you really need dedicated instruments. Kerrison punches are great instruments for precisely cutting through bone and mucosa, and angled instruments are essential in accessing that frontal recess without ripping out sinus mucosa. In more extended procedures in the frontal recess, a drill I find is essential. And it's taken me a little while really to find the best drill system. The two I use at the moment is the Medtronic 30,000K burrs. They fit onto the M5 handpiece. They run at 30,000. There's a lovely range of cutting burrs, and the angle can go from 40 degrees to 70 degrees. It both has suction and irrigation at the same time. The Midas Rex drill with a skull base attachment is a very nice long thin drill with irrigation but no suction, and it runs a lot higher speed. Intraoperative navigation, if you've got access to it, that's great. It is no substitute for knowing anatomy, but it's actually really great to confirm where you are and really speed progress along when you're doing sinus surgery. So for a simple endoscopic approach to the frontal sinus, these are the essential bits from my point of view. In normal sinus surgery, I tend to have the head position in a neutral position. If I know I'm going to be having to look at the frontal recess, I tip the patient's head further back. And that's really to improve my angle to the frontal recess, and also allow instruments so they don't actually hit the patient's chest. And in all the cases, I'll use an axillary flap approach. I'll show you that in a moment. Why? Well, it allows most of my dissection in the frontal recess to occur with a 0 degree scope. I can use a flap at the end if it's still there to enhance healing over any exposed bone. And in the post-op situation, you've also improved the angle for the patient to irrigate that frontal recess and sinus. In the simple approach, we're basically removing obstructed cells and preserving outflow. So here's a quick video. In the left nostril, we're making an incision above the axilla of the middle turbinate, about 1 centimetre, and 1 centimetre anteriorly, and then cutting into the axilla of the middle turbinate. This flap is then raised directly down onto bone and pushed back, and we can just store it between the middle turbinate and the septum. The next thing is really to remove the anterior face of the agonasa cell. And the Kerrison punch is an excellent instrument for this. Once that face is removed, we've really improved the visualization of the frontal recess. We're using a section curette now just to explore where that frontal recess pathway is. And I think the important point in this frontal recess now is not to grab mucosa and rip it out. It's really precision cutting of any cells and using fruit cutters or a microdebrider to remove precise bits of mucosa and preserving as much mucosa around that outflow tract as possible. You can then fracture cells to improve access into that frontal sinus. If I'm having to do more, and that means I'm going to have to use a drill, again, the head position is important. But having access to a drill that's thin and has high speed, and having lots of irrigation and plenty of patience is really an essential step. And I have to say, whenever I use a drill in the frontal recess, I'm either going to be doing a draft 2B or a draft 3. One important landmark I like is the first olfactory nerve. I find this is an excellent landmark for the floor of the frontal sinus. If you can dissect in the roof of the nose, medial to the middle turbinate, and dissect along, you will find the first olfactory nerve. And typically you will find a little blood vessel and then a triangular bit of bone. And that first olfactory nerve is the posterior limit, the start of the cribriform plate. Anything anterior of that is going to be safe to remove. Another important landmark is the anterior face ethmoid bulla if it's there. And then posterior, you've got the anterior ethmoid. The olfactory nerve, I think, is an excellent landmark because one of the questions is, why are you doing frontal sinus surgery? It may be it's full of polyps, it may be a revision surgery, the anatomy may be very difficult. That first olfactory nerve is in a place where there's usually little pathology and usually people haven't been there before, so it's quite a good landmark. I'd just like to show you this. And at the start of the operation, in this right nostril, we're just going to make an extended flap. I'm going to make a septal flap and join it to an axillary flap. So we've got a big U-shaped piece of tissue based posteriorly. The incision here is about halfway down the middle turbinate and about 2 centimeters in front of it. And we take that incision right up into the roof of the nose. We're going to join that to the axillary flap, which we're just dissecting out there. So we're dissecting it over the middle turbinate. Just make an incision just to release the axillary flap from that axillary of the middle turbinate. We can then dissect right into the roof of the nose. And here we can see the blood vessel and then the olfactory nerves in the distance. Anything anterior to that is going to be the floor of the frontal sinus. So that's the flap just showing you where it was, and we'll tuck it out of the way. And the first thing I'm going to do is open up the anterior face of the agonasal cell. So probe just going anterior face ethmoid bulla, trying to locate where the frontal recess would be. Kerrison punch again to take off the anterior face of the agonasal. And then we've got the landmark of that first olfactory nerve. And you'll see we can progress very quickly with the drill in that floor of the frontal sinus to gain access into the frontal sinus itself. And very quickly now, we're gaining access into that frontal sinus. Larger there will be inverted papilloma. After we finish the procedure, we've got all that flap material. Now, in reality, not all of it stays intact. And if it does become free, you can use it as a free graft. And basically wanting to put mucosa over any of the exposed bone which we've made in our dissection. If it's free tissue, then I'll glue it in place. I'm going to have a break there for any questions.
Well, we've had no questions come in from the chat thus far, but if anyone's got any questions for Mr. Nix, now's the best time to ask them.
Well, if we're short on time, perhaps I just carry on for a moment then.
I think that's probably best, Paul. That'd be great. Thank you.
Yep.
So gaining access to the frontal sinus, we've got a number of techniques, but the next question is how and when, what do we do? Now, this is quite a busy slide, and it's taken from a very nice paper by Anshul Sharma, and the paper's written basically for frontal mucoceles. But I think it's quite a nice framework for how I view the frontal sinus. Let me try and take you through it. We're talking about where the pathology is in the frontal sinus, whether it's medial or lateral, and that's either pathology or how we enter the frontal sinus. If it's medial, then we can, the pathology or the sinus medial aspect is medial to the lamina papyracea. If it's intermediate, it's between the lamina papyracea and the actual medial wall of the globe of the orbit. And if it's in the lateral aspect, it's lateral to the medial wall of the globe of the orbit. And depending on where you think you can get access to that frontal sinus would dictate what type of operation you may want to do, whether it's a draft 1 to a draft 3. And I think the beauty of the paper is really getting me to think about how much access I will need. And if the anterior to posterior diameter is very small, that's from the posterior skull base to where we may drill off on the beak, something less than 1 centimeter, then that's going to be very complicated to maintain long-term patency. So now we have the idea of a ladder. And to approach surgery in the frontal sinus, we want to start at the very bottom if possible, and then only work our way up as things get progressively more difficult with what we're dealing with. So if it's a very narrow AP diameter, I would step up the ladder. So instead of thinking about a draft 1 procedure, I'd be thinking about a draft 2B procedure. If there's osteoneogenesis in the frontal sinus, that really makes long-term patency very difficult. And certainly in my early days, I've done operations, being very proud of myself to open up the frontal sinus, and 6 months down the line, it's just reached the nose down. So being aware of what the long-term patency is on frontal sinus surgery is absolutely essential. So hopefully you're getting the concept. We'll try and start as simple as possible, do as little as possible to frontal recess, unless there's complicating factors, and then we'll start stepping up the ladder. And again, those complicating factors are things like osteomas, POTS, puffy tumours, malignancies, inverted papillomas, if there's bilateral disease, if there's revision surgery. But also important to the concept of going up the ladder is actually just stepping off the ladder. And really you need to step back off this ladder if you're dealing with a hot sinus. So if you've got an acute frontal sinus, operating and drilling in frontal recess can really have long-term complications for you. It would be far better to treat the frontal sinus with steroids and antibiotics and a simple drainage such as a mini trephine, rather than go in and try an instrument and especially drill in that frontal recess. So it's the concept of trying to do things as simply as possible, but knowing when to step up the ladder and do a lot more extensive operation depending on the pathology, and jumping off the ladder if there's acute infection. We've talked about really an endoscopic approach to that frontal sinus, but there are difficult cases we all come across. And there are two things that I will start thinking about if I'm having problem access to that frontal sinus, especially if there's lateral pathology. And one of them would be a combined nasal orbital approach. And essentially, I'm going to open up 2 ports. I'm going to have my endoscopic approach through the nose, but I'm going to open up a lateral port through an eye incision in the floor of the frontal sinus laterally, so I can pass instruments or the camera from the lateral aspect, as well as have access via the nose medially. If I've got the opportunity, I'll typically ask my ophthalmology colleagues to help me out, because they are very good at doing a lovely lid incision, which is very cosmetic when it heals up, and they can gain me access to the floor of the frontal sinus laterally. And then the osteoplastic flap. In my hands, I'll always do a cranial incision, and because I don't do many of them, I usually ask one of my neurosurgical colleagues I work with to raise the flaps for me, and then we open up a bony window. But again, it's a combined approach. The osteoplastic flap gives you fantastic access to that frontal sinus, but that's usually in combination with an endoscopic approach as well. So finally, the frontal sinus really requires respect. You can operate in the frontal sinus, be very pleased with yourself at the time of the operation, but 6 months down the line, it can be all stenosed off and you're back to normal. So plan the least invasive approach. Think about medical therapy. And if you are going to drill in the frontal sinus, I would go for a draft 2B or a draft 3. And that's because I don't want to traumatize that sinus mucosa unless I can open up really widely. The essence is really to preserve as much mucosa in that frontal recess as possible. And if we are exposing any bone, then try and graft it. I'd like to thank you very much for listening and open to any questions.
That was brilliant. Thank you, Paul. Have we got any questions for Mr. Nix? Just pop them in the chat. We'll just have about a minute for that, and then we'll move on to the break. Just while we're waiting for maybe 1 or 2 questions to come in, Paul, just in the COVID world, you know, we're talking about the frontal sinus and drilling and things. Are you going to change your approach slightly, you know, until everything settles down? Or are you still going to, if you need the drill, kind of make some changes to how you're going to kind of use it during these procedures?
I know Ansel Sharma gave a very nice talk in the COVID era in the frontal sinus, and he was stressing try medical therapy as much as possible. But as we're starting to open up services, and this isn't going to go away for at least a year or so, we're going to have to approach it. And
yeah,
I'm not essentially modified my technique. Obviously, we have full PPE, and I will tend to just wash the nose through with a dilute providine iodine solution, but otherwise I would be still drilling up in that frontal recess. One of the papers from Wuhan, which sparked a lot of this off, and said a lot of the theatre team actually got COVID from a pituitary operation where they were drilling. They actually published saying that none of the theatre team actually got COVID from the procedure. I think that's probably because they were all using PPE, and the actual people who got COVID from that patient were the people who looked after him on the ward.
Yeah. Okay, we've got a question just asking about a balloon sinuplasty and just saying, how long do you keep the balloon up for when you're doing your sinuplasty?
I thought a better question might have been, when do you use a balloon sinuplasty? And that's one I can't really answer too long. Keep it up for a minute and then let it down. Usually it requires 3 passes. I think it'd be a very good procedure for a person who gets repeated barotrauma of the frontal sinus. I think one of the big issues for the NHS is its cost.
Yeah. And
to mitigate the cost, putting that into an outpatient local anaesthetic setting is probably the future.
Okay. Well, that was brilliant. Thank you very much, Paul. That was a great talk.